All right, so the recording, I don't want you to use it as study purposes. It's educational, and a lot of those seizures aren't necessarily real. But did you see how many different types there were? Have any of you guys seen someone have a seizure, or do any of you guys have a seizure disorder and wish to share? What, Kelsey, the patient that you, or the friend or whoever it was, what did their seizure look like?
So she recently got diagnosed. This is my friend's little sister. We were at the pool and she basically was like standing and walking to the slide and she just kind of like fell backwards.
Okay.
And but they think that she's been having seizures in her sleep for like a long time.
Gotcha. So when that took place, did she have did she lose consciousness altogether, or did she just lose complete muscle tone?
She lost consciousness and she didn't even know what happened.
Okay. Was she afterwards? Was she very, very tired? Was she kind of not herself?
Oh yeah.
Okay, so it helps that you've seen that. Catherine, the person that you saw, what did their seizure look like?
Kind of the same with Kelsey. Like we were on the cheer team and it kind of first started happening like when we were at cheer camp and we were on the beach. My book just fell. I am so sorry. We were at the beach and she like kind of went unconscious and we thought she just like passed out from like heat. And then like later throughout the week of cheer camp, we realized that like she was actually like seizing, like because she would just like go unconscious and like pass out. And she like started having like major episodes. So they had to like she would just like pass out and then she would like she would have an episode for a few minutes and then she would just kind of wake up and like not know what happened.
Mm-hmm.
But she just kind of was also like oblivious that she was having episodes. Like she didn't believe that she was actually doing that. So she kind of like kept fighting through it and then once it got really, really bad, she was like, okay, like I need help.
Gotcha.
It was crazy.
Has anyone seen a seizure where the patient or the friend or whatever just kind of checked out for a second, but didn't necessarily have any of those major issues like that, but kind of just went from talking to you and then just like totally like stared off into space, completely checked out, and then kind of acted like it didn't happen and just kind of picked up where they left off? So all of those different things we're going to talk about. There's so many different types of seizures. They can be found on because I want to show you, I don't know where it can be found. Okay, on page 314, there are generalized seizures and focal seizures. So I want to talk about that briefly because there are a lot of different medications to treat seizure disorders, okay? And they are often they're often prescribed based upon the type of seizure that you have, right? So a generalized seizure, there's some subcategories under generalized seizures. So an absent seizure involves loss of consciousness with a vacant stare or unresponsiveness. That sounds like what your friend Catherine, obviously I'm not a neurologist and I can't diagnose, but she lost consciousness and she didn't do the whole like, y'all didn't realize she was having a seizure because she didn't do that clonic tonic shaking on the ground stuff, correct? Okay, right. So did someone say something? I'm sorry.
Yeah, I just said yeah. I just said
yeah.
Right.
So that sounds like the type of seizure that she had. A myoclonic seizure involves sudden, forceful contractions of single or multiple groups of muscles. That's myoclonic. So, I mean, I don't want to like demonstrate for you guys, but these are the more seizures where you're like, oh, they're having a seizure. Those traditional kind of jerking type things. Clonic is longer jerking activity. You can have a, tonic clonic, which is alternate contractions and relaxation. I mean, those are the more forceful, like they're contracting and they're relaxing and they're really having a full-blown, they're all full-blown seizures, but those major myoclonic seizures. And then atonic is a loss of muscle tone and a person suddenly drops. So they just drop down, like all of their muscles kind of just become jello. So those are all types of generalized seizures. Focal seizures, where the staring seizure that I talked about, consciousness is not impaired. It's more these simple seizures, simple focal seizures can involve senses or motor ability, nausea, like a deja vu feeling. So sometimes these patients do not, they don't completely check out. They're just, a lot of, when you said they often have them in their sleep, your family member's friend, they're likely having simple seizures in their sleep, where the lights will kind of flash, not actual, they'll kind of have this sensation of light flashing, or it'll just be like one little part of their body will twitch like that. It's not, but they're still coherent. Complex, consciousness is impaired. And then they can have that staring gaze and hallucination type thing. So a lot of it has to do with, do they lose consciousness or do they not lose consciousness? I'm not going to ask you a whole lot to differentiate. I am going to point out when we look at these, the treatment over here, you will see, that some of these medications are used only for focal treatments, focal seizures, and some are used for for tonic-clonic. I will point out those biggies like that. But I mainly need you guys to know, in regards to assessment, that when we're asking a patient about their pain, what are some of the things that we're asking them? We're talking about pain right now instead of seizures. I'm sorry, Kat.
Where the pain is.
Where the pain is. What else are we asking them?
Scale of 1 to 10.
Like?
The intensity of the pain, scale of 1 to 10. What else are we asking them?
What the pain feels like if it's radiating or not.
Absolutely, positively. So it is not acceptable for your patient to just say, I'm in pain. Am I right? We all agree that that's not acceptable, that as nurses, we must say, tell me more about your pain. Where is it? And asking those questions. Is it radiating? What it was the preceding factors. What are the alleviating factors? All of these things, frequency, duration, we're asking about pain. Would it not make sense that we were asking those same things if our patient says that they have a seizure? These seizures can exhibit very, very different. So if your patient just says, or if a mother says my child has a history of seizures, not sufficient, okay? I need y'all to look at the box on page 317. We need details. We need to know a description of the seizure. Just like I asked y'all at the beginning, Kelsey, and I said, what did your friend look like? What did your friend's sister, what happened? Catherine, what happened? You need a description of the seizure. I cannot say seizure, apparently. A description of the seizure. You need to know the frequency. Did it last 2 minutes or did it last 10 minutes? Because there's a significant difference there. So the length of the seizure and the frequency. So how often? Did this happen one time or did it happen every day at cheer camp, Catherine? Those are things that are going to make a very, very big difference in your patient. Did they have an aura before it took place? Did they see those flashings of lights or have a weird smell sensation? All of those things are incredibly important to take into account, because while we are going to educate on these medications that we're giving for these seizures, we're also going to educate them on their disease process. And if you're associating that aura before you have a seizure, we probably want you to go sit down, so that you don't hit the floor whenever, you feel this seizure coming on. What was the degree of impairment? Did they lose consciousness or did they not? And what, if anything, appears to bring on the seizure? If when we watch a movie and it says, like at the beginning, it says, somebody help me, I can't think of the exact term, but it'll say, the video games, they'll say, there's depictions of strobe light effects, whatever, if you are I can't remember how it says it, but basically if you know that this causes you to have seizures, this may induce seizures, you shouldn't watch this movie. So some people know that those things bring on their seizures, and that is our job as a nurse. We may not diagnose these seizures, but we are going to educate them accordingly, very, very much so. So that's my little spiel before I start my, before I start my little education on the actual drugs. Questions, comments? Anybody want to say anything about seizures?
I have a question.
Mm-hmm.
Oh, I go.
See? Okay.
I forgot my question. Okay. So like, if I'm trying to figure out if this is a seizure or not, probably not. But like, say someone's asleep and they constantly jump in their sleep, like it's
So
like,
that's usually, I know exactly what you're talking about. That's usually something different. That kind of, you feel like you're falling, and you're like, oh, and then they kind of go back to sleep. That's usually not a seizure.
okay.
I don't know the name for it, but it's usually not. It's usually more of like a sensation of relaxing and your body kind of feels like you're falling. I'll look up the name of that for you, but it's usually not a seizure.
Just because like it's like multiple like times in a sleep that it happened. So I was just wondering if that was like anything correlated to seizures.
I mean, potentially, but not usually. Most people do that as as their body relaxes. It's kind of like a normal, relaxation mechanism. But I'll look it up. It has a name. I'll look it up for you. But if you're concerned, obviously, with anything, if you're concerned and it seems excessive or more than the norm, you can always get an EEG done, or, not you specifically, but, the person you're concerned about, they could always look into it a little bit more and have a sleep study or something like that. Okay, so all of the drugs, our big umbrella that we're about to talk about, are anti-epileptic drugs. Epilepsy is the term. If you look again, I feel like y'all aren't as familiar with these. Are the key terms looking less familiar to you guys? Like you're kind of feeling like, I don't always know all of these. Make sure you know them, because I don't always go through them, but y'all have to know key terms. So epilepsy is a chronic recurring seizure disorder. So just like we said, one episode of high blood pressure doesn't make you hypertensive. One seizure doesn't necessarily give you epilepsy, but repeated chronic, more than one, they will be diagnosed with epilepsy. So we're talking about anti-seizure drugs or anti-epileptics, okay? All right. So the drug categories used as anti-epileptics are the hydantoins, the carboxylic acid derivatives, succinimides. Y'all know I'm struggling with some of these words because we don't use the full word. Oxydiazepines, benzodiazepines, and non-specific drugs. And a lot of these drugs, again, are going to have drug-drug or drug-food interactions. And our biggest things with these are going to be education and assessment related. So they all have different mechanisms of action, and they're often used based upon the type of seizure, what the physician feels is the reason that the seizure is happening. They're often trying to target that. So what I would like to talk about briefly, when we talked about heart medications and we talked specifically about the antiarrhythmic drugs, remember we talked about, I don't know how much y'all remember about brain synapses and motor neurons and all that stuff. But remember in the heart, we talked very specifically, this is, it's an electrical problem. When we talked about antiarrhythmics, there was something going on with the electric problem of the heart. With the electric, the normal electricity through the heart. The same is often true in the brain in regards to seizures. Something is happening, either those neurons are overly excited or there is a misfire. Oftentimes that is, what is going on with these, why people are having seizures. So hydantoins, they stabilize the hyperexcitability postsynaptically in the motor cortex of the brain. So what that means in simplified terms is they make those synapses less sensitive to those. If they get a misfire, they're not as prone to say, oh, I need to have a seizure. They're just not as sensitive. They're kind of desensitized to those fires. Does that kind of make sense? Okay. The carboxylic acid derivatives increase levels of gamma and GABA, which stabilize cell membranes. So again, just a different mechanism of action. Succinimides depress the motor cortex, creating a higher threshold before nerves react to that convulsive stimuli. So we can either, I'm not going to ask a whole lot on these mechanisms of action, but I do want y'all to understand how they work. We can either make those synapses less excited, or we can make those nerves less reactive. Is that making sense to y'all in regards to how we are making these how these medications work? We can decrease the repetitive synaptic transmission of nerve impulses, can elevate the seizure threshold, or we can have differing, so non-specified can have differing properties. For example, they can be GABA agonists. Topiramate blocks the seizure activity rather than raising the threshold. So at the end of the day, however they're working, they are somehow affecting as a whole, anti-epileptics as a whole. They are either increasing the threshold of what those synapses and what those neurons can experience before they react, or they're increasing the transmission, or they are, slowing the transmission and slowing the response. So they can be used prophylactically following trauma, neurosurgery, or tumor. So my mom, she had metastatic breast cancer, and it went to her brain. She never experienced a seizure, but when she got that diagnosis that the cancer was in her brain, they automatically put her on anti-epileptic drugs, because it would make sense that if we have a tumor in our brain, we're going to have some misfires, right? Or some oversensitivities. So oftentimes seizures, sometimes seizures you just have seizures. Sometimes that's your plight in life. You just have some misfires in your brain. Someone sharing their screen by accident. Let's see. Can y'all still see mine or no? Did it go away?
It went away. It's Carly that's showing your screen.
Okay, let's see. Let me get it back up for you guys.
Okay.
Sorry. It's okay. It just kind of all disappeared. It's the day of technical difficulties. It gives me a chance to take a sip of my coffee. I'm slurping extra loud, I'm sorry. Okay. So the reason I wanted to mention my mom is because she didn't have a primary seizure disorder. She had potential seizures secondary to something else. So that's going to be happening with a lot of your patients. They may get into a car wreck and have some cerebral edema, which may place them at risk for seizures. Are y'all kind of with me as far as like those things, any kind of trauma, brain trauma can cause that. Tumors, that's all that's really coming to mind right now. But I just want y'all to know that a lot of times seizures can be secondary to other things. And so we should always, our assessment skills should always be point on if there's any kind of abnormality as related to the brain. We always kind of want to have seizures in the back of our mind. So anti-epileptics are used for seizures of all types, for neuropathic pain, for bipolar disorder, and for anxiety disorders. So oftentimes, a lot of this stuff crosses as well when we talk about those synapses and we talk about all the neuro transmitters in the brain. A lot of times, in addition to seizures and all of these other things, anxiety can be caused from these things. So this is one of the things that I've seen in my students. If a patient is on gabapentin, traditionally, gabapentin or Neurontin was a seizure medication, but they noticed along the way that it also helps with treatment of chronic pain, even though it's not a pain medication, per se. It helps with chronic pain, helps with things like fibromyalgia, and it helps with things like neuropathy. So sometimes students will see that and they'll see it as an anti-epileptic. And so when they go in to give their patients their medicine, they'll say, oh, I have your seizure medication. And you know what the patients say? When did I start having seizures? It's not only used for that, okay? So some of these medications are strictly used for anxiety. They're strictly used for, and I'll try to point those out to you. They're used for things, for other disorders outside of anti-epileptics, but they're still in that anti-epileptic group. Y'all with me still? Okay. All right. Adverse reactions. All of the subcategories as a whole: drowsiness, weakness, headache, somnolence, nystagmus, ataxia, and slurred speech. All central nervous system reactions, which makes sense because we are acting in most cases directly on those neurotransmitter or those synapses in the brain. All those kind of make sense to you guys? If we're slowing impulses or we are, messing with neurotransmitters, it would make sense that all of those things would take place. Nausea, vomiting, anorexia, constipation, diarrhea. You need to highlight gingivital hyperplasia. That is overgrowth of the gums and is specifically related to hydantoin use. Hydantoin. I think I spelled that right. Other reactions are skin rashes, pruritus, urticaria, urinary frequency, skin reactions, and hematologic changes. Phentoin is not given to patients with sinus bradycardia and heart block. We're going to go over some of this. I'm going to show y'all a box in the book in a second that you kind of need to make note of as well. Succinimides are contraindicated in patients with bone marrow depression, as is carbamazepine. Okay, I would like for y'all to look at the chart. This is something that I'm probably going to have as a matching thing. I haven't made your exam yet, but I feel like it's something that I want to be a matching thing on your test. These specific drugs, there are certain things that we're going to monitor in regards to their labs. This is on page 317, table 29.1. we know that these drugs can specifically impact like y'all cannot get it out. Carbamazepine, I said it wrong, can affect your white blood cells. So we are going to, if our white blood cells are decreased, what is going to happen? What is your patient at risk for? Low white blood cells.
Diseases, sickness.
Infection.
Yes, infection. If the white count is super low, then your patient is at an increased risk for infection. So we are going to monitor these things closely on these patients. For phenytoin, that's Dilantin, is the name that we always use it. That's why I can't say half these generics, but I try to give you all the generic name. There are levels that are done for that. And we want to make sure that your patient stays within range. It's one of those drugs, if we can be therapeutic, we never want to go over that 20, in that range, but if you can be therapeutic at 8 or 10, it's more about having a baseline for your patient. Of course, we're worried about toxicity, but we're more worried about, instead of just saying you have to stay between 10 and 20, we need to know the patient has an effective, they're not having seizures if they maintain a baseline Dilantin level of 12. We want to keep them around their range that's effective for them. Does that make sense to you guys? More so than just saying it has to be between 10 and 20. We want it to be therapeutic for them on a personal level. So that's noted on page, I'm just going to try to find it for you guys. Special considerations, this is on page 318, special considerations for idantoins. Phenytoin remains a commonly prescribed anti-epileptic because of its effectiveness, low toxicity, and relatively low cost. However, genetically linked inability to metabolize phenytoin has been identified. For this reason, it's important to monitor serum concentrations of the drug on a regular basis to detect signs of toxicity. Phenytoin plasma levels between 10 and 20 give optimal epileptic effects. However, many patients achieve seizure control at lower serum concentration levels. So that's just something that I want y'all to know. If your patient is if they are measuring lower, but they are still maintaining a relatively seizure-free life, then that's okay. But if they're above 20, then we're in the dangerous range for phenytoins, okay? All right. So benzodiazepines, we're going to talk about at length in our chapter about anti-anxiety medications. But benzos are used cautiously during pregnancy, are used cautiously in patients with glaucoma, and they're used cautiously in elderly or debilitated patients. Elderly patients often hang on to benzos for a long time. They don't metabolize them as quickly and they don't excrete them as quickly. So they're going to have prolonged side effects with benzos. Benzos end in PAM, P-A-M. Those are things like lorazepam, diazepam, those medications. And we really want to monitor closely because they cause extreme drowsiness. They're on page 321. And they can, because they cause a lot of drowsiness, safety is going to be a big, big priority with these drugs, okay? Okay, now y'all are starting to see the anti-epileptic drug classes have a lot of drug-drug interactions, okay? And they also have a lot of interactions with other disease processes. So phentoin, we're going to be super careful if your patient has hypotension or myocardial insufficiency. If anybody has a history of intraocular pressure, these medications are sometimes dangerous for them. So you see all these interactions? It's a lot of them. The main stuff, oral contraceptives and anti-seizure meds they don't go together. Alcohol and anti-seizure medications do not go together. And a lot of tricyclic antidepressants are dangerous with these medications. Y'all remember I told y'all theophylline interferes with a whole lot of things. Here it is again. So that's why it's incredibly important to know all of the medications that your patient takes and to be a good information gatherer. All right. Vital signs. So as far as our assessment goes, we talked about gathering information in regards to what their seizure looked like. We also need to know their vital signs so that we can have a good baseline. And that thorough patient history is key. I've told y'all most of this already. Carefully document each seizure with regards to the time of occurrence, duration, psychic or motor activity occurring before, during, or after the seizure. Get all of that information so that you can adequately know if your medications are being effective, B, so we can make sure they're on the correct medications. We need to know their response to therapy. Serum plasma levels for anticonvulsants are measured. Specifically, what drug? Do y'all remember? What drug class? They're all like, no. Phentoin. Dilantin drug levels. Okay. We know our diagnosis. Risk for injury. Risk for impaired skin integrity. Risk for infection related to the immunosuppression of some of these drugs. Impaired mucous membranes related to gum overgrowth. Do y'all remember what that was called? I think I heard you or saw you say it, Kelsey, but you're muted. Gingivital hyperplasia, overgrowth of the gum tissue, okay? Our expected outcomes, we know we want our patient to have an optimal response to therapy. We want them to be compliant. Compliance is a big deal. Um, 25% of patients will stop, reduce, or change their own anti-epileptic drugs because of unpleasant adverse reactions. That is pretty solid, don't you think? 25%. 1 in 4 people are going to say, I don't need this. It makes me nauseated. I'm tired of feeling sleepy all the time. I haven't had a seizure in a while. So they will change these medications on their own to fit them. So your job as a nurse, we want to encourage compliance, but with anything, we need to know, why don't you want to take this? What is going on specifically? Why are you, what are the unpleasant reactions that you are experiencing? So we can kind of further delve into this. The monitoring for more severe adverse reactions, such as life-threatening skin rashes and decreased blood count, should be done regularly. Those are incredibly important things to keep in mind in regards to educating your patients and planning for anti-epileptic drugs. Okay. If you are giving a medication from the barbiturate drug class, which are often, I don't even think they're listed. Blood pressure is incredibly important. So benzos, we talked about dosing very closely, especially in the elderly and debilitated patients. And diazepam is not to be mixed with other drugs. These will be often given IV for seizures. And then our ultimate concerns with seizures, on top of safety, if a patient is having status epilepticus and they are having seizure after seizure after seizure, their airway becomes impaired, right? Those are the things that obviously we're concerned about safety and we're concerned about these other things. But when their airway becomes compromised because of seizures, those are the things that are life-threatening and must be treated emergently. Being diagnosed with epilepsy is a big deal because oftentimes these patients, you'll want to refer them to like the Epilepsy Foundation and different things like that for support, because when you get a diagnosis of epilepsy, dependent upon the medications that you're taking, the frequency of your seizures, the type of seizures, these patients are often not allowed to drive anymore. And that is a huge, huge deal in regards to taking away someone's independence and taking away, like, that's a hard pill to swallow. If I told you guys today, sorry, you had a seizure, you can't drive for 6 months, how much would that affect your life? It would very, very much affect your life. It would make you feel like a burden to your family. It would affect your school and your job, all of the things that you enjoy to do. So oftentimes, your patients who are on anti-epileptic drugs really need that support that can be found through those foundations, okay? So that's something we don't want to just think about their physical health. We want to think about their mental health as well. If patients are on these drugs, we want to assist them with their ambulatory activities. We want to make sure that if we're giving pills, okay, so I need to talk briefly, the post-ictal state after someone has a seizure, especially a generalized, like a big seizure, a clonic-tonic seizure, they have something called the post-ictal state. And in that state, it's almost like a recovery stage for their body. Everything is slowed down. Like they're coming to and they're awake, but they are so tired, like that they just can't hardly function. And they sleep, their heart rate's a little bit lower, they're less responsive, and in regards they're responsive, like mentally responsive, but their speech might be a little bit garbled and they're very, very tired. That's called the post-ictal state. If you are administering medications, you have got to make sure that your patient is awake and alert enough to swallow. You can't just say, here, have this. You have to really assess that swallowing. Make sure that they're taking a sip of water first. Make sure that they're staying awake and they're not falling asleep while you're putting a pill in their mouth, okay? Let's see. We want to be alert for signs of pancytopenia. So if our patient has a super low white count, then they might complain of sore throat, fever, general malaise. They might just be generally feeling unwell if they have a low white count. If they have a low platelet count, they'll talk about having easy bruising, bleeding of the gums, those sort of things. So CBCs are important, and they should be monitored periodically because they'll test both the white count and your CBC is your complete blood count. So it'll tell us our white count, it'll tell us our platelets, our red count, all of that. We want to periodically inspect the mouth, teeth, and gums. And we want to educate that the nurse needs to assist the family with this adjustment to diagnosis. Like I told you, it's a big deal. Explain the importance of restricting some activities until drugs are controlling the seizures. Other modes of transportation, you may have to introduce them to, riding a bus or some of these things that are just not their norm, making sure that they have the resources that they need. The hydantoin, what is the overgrowth of gum tissue? What is that called?
Gingival hyperplasia.
Yes, gingivital hyperplasia. So patients need to know the longer we are on these drugs, the longer, the more significant those things will be, the overgrowth of that gum tissue. So their dentist needs to be aware that they're on these medication, and they need to go to the dentist periodically. We want to tell them to take these meds with food to decrease GI upset. We want to make sure if they're taking phentoin liquid that we need to make sure it's shaken well. We want to make sure yellowish discoloration of the skin or eyes. What would that be indicative of? Do y'all know?
Jaundice.
Yes, jaundice related to what? What does jaundice have to do with?
Liver.
Yes, liver problems. So any of those things we need to know. We need to know if they have an unexplained fever, sore throat. All of those things will key us into these adverse reactions of these drugs, okay? All of this, if they're having a rash, it's important for us to know about that. Tridione, on page 321, it can cause photosensitivity. So just like we did with our sulfonamides, we want to make sure that they're wearing protective clothing. If protecting clothing is not an option, sunscreen is a secondary option, but protective clothing and staying out of the sun is what we want these patients to do.
Which drug did you say?
The drug is, I butcher this drug class, I'm sorry. It's oxazolinidones. The drug is Tridione. Is the trade name. The generic name is trimethadione. It's on page 321, that top one. All right, and at the end of the day, we want our patients, we want to ensure there's no injury, that they are, their drug is therapeutic, that they're compliant, that they trust you as a nurse and they report those adverse reactions. They understand the importance of follow-up care, and that they know when they're supposed to take the drug, how often, all of these things. All right.